Implementing workplace interventions to promote mental health in the workplace. My name is Dr. Birgit Greiner. I'm with University College Cork, and I'll be the main facilitator of this webinar together with my colleague, Professor Margaret Maxwell from Stirling University. Now, this webinar was created in the context of the MENTUPP project, which is involved in promoting mental health at the workplace, and you will hear more about this project and also about our plans. I will lead you through the agenda now very briefly and also introduce our team. Now, that's what you can expect today. First of all, we will present our results about a systematic literature review of the published and unpublished grey literature on what we know about mental health interventions and how to best implement them, and what are actually barriers and facilitators to mental health interventions in workplaces. And then we will divide up and break up out rooms, and it will be actually your chance to share your thoughts and experiences with us about your own barriers and facilitators in your organizations. We invited participants to this seminar from a wide range of stakeholders. We invited management, leaders from different organizations. We invited representatives from professional bodies, and we invited academics. So we'll have a very interesting mix of people here to share their experiences and thoughts. Then we will have come back into the big group again and summarize these important discussion points. And we'll also review next steps for the MENTUPP project, and the principal investigator, Professor Ella Ahrensman, will present those to you and maybe have also some kind of invitation to you. And then we close, and my colleague, Professor Margaret Maxwell, will summarize the results of this webinar. So let me briefly introduce our team to you and also the MENTUPP project. For those of you who don't know the project and haven't been involved in it, the main aim of our project is to improve mental health in the workplace. And we are developing and implementing and also evaluating a multi-level intervention to target mental health difficulties and to improve well-being. Now, there's also a secondary aim here to reduce actually depression and suicidal behavior in organizations. And this is done, as you see from the map, in several countries. So we collaborate with 16 partners in Europe, in Australia, and North America. Next slide. This is our team. Professor Margaret Maxwell from Stirling University, Dr. Charlotte Patterson, also from Stirling University, Dr. Caleb Leduc from University College Cork and the National Suicide Research Foundation. The next person is myself. I'm with the School of Public Health at UCC and also the director of the MSc in Occupational Health. We have Dr. Birgit Aust from the National Research Center for the Working Environment in Denmark. And we have Professor Ella Ahrensman from University College Cork and the National Suicide Research Foundation, who is the principal investigator. All right, I hand over to my colleagues to present the results of the systematic review to you.
Morning, everyone. So we wanted to start by thinking about why we would want to study implementation of workplace mental health promotion interventions. And well, evaluations can be used to assess whether interventions are effective. So is the intervention reaching its goals, for example, to reduce symptoms of depression or to improve the level of mental health related stigma? However, the intervention needs to be implemented well for these evaluations to be of good quality and for the intervention to be able to actually reach its goals. So this means that the intervention needs to be delivered in a way that it's available to people, that they're able to access it, that they can accept it, that they can choose to engage with it, and that they continue to engage with it. So identifying factors that influence how and why interventions might be implemented or delivered is helpful because it can improve the implementation of the intervention overall, which can improve the quality of the evaluation, and it can also increase the likelihood that the intervention is going to be effective, because if the intervention isn't delivered properly, it can't reach its goals. Next slide, please. So we looked at, we conducted a literature review, which the protocol for which has been published in systematic reviews. And the aim of the review was to identify what evidence there is about implementing mental health promotion interventions at work, and what does it say about the barriers and facilitators to doing so. So we used scoping, review and qualitative evidence synthesis methods to do this, which I'll come back to very briefly in the next slide. And we searched databases and grey literature between 2008 and 2020. And we included studies with explicit information about implementation assessment. So the main outcome of the review is to increase the understanding of factors that influence successful delivery of mental health promotion interventions in the workplace. Next slide. So the review was split up into two main aims, the first one being to identify and document research explicitly reporting on the quality of delivery and implementation of mental health promotion interventions, and if the evidence allows it, specifically in the ICT, construction and healthcare settings and SMEs. So this maps onto the research question, what is the scope of research with explicit analysis of implementation aspects of mental health promotion interventions in the workplace? And we used scoping review methods to answer this question, which, to give you a little bit of background information of that, it allows you to describe the kind of evidence that's available rather than going into any more in-depth analysis. That was saved for aim 2. So the second aim was to identify the barriers and facilitators associated with the quality of implementation of mental health promotion interventions, and again, if the evidence allows, specifically in ICT, construction and healthcare settings and SMEs. So this aim maps onto two research questions, the first one being a little bit more general. So research question 2 was, what are the barriers and facilitators to implementing mental health promotion interventions in the workplace? And then research question 3, a little bit more specific, what are the barriers and facilitators to implementing mental health promotion interventions in the workplace, in SMEs, in ICT, construction and healthcare sectors? So we used qualitative evidence synthesis methods to answer these two questions, which just allows for a little bit more of an in-depth analysis, so able to identify some more in-depth information about those barriers and facilitators. And today we're going to be presenting the results from research question 3, so specifically looking at these sectors and SMEs. Next slide. So this slide just shows you a flow chart of the number of studies that we identified during the searches and how they were filtered out at what stage, and then the number of studies that we actually included. So I'll just take your attention down to the bottom 3 boxes there. To answer research question 1, we included studies reporting an explicit investigation of intervention implementation, and any studies that reported rich data on any implementation outcome. So we had 59 studies, primary research studies, as well as 10 reviews included in research question 1. Research question 2, again, was that more in-depth understanding of barriers and facilitators. So to achieve that, we sampled studies from research question 1 that we judged to be reporting very rich data, so providing information that would allow us to get that in-depth understanding of the barriers and facilitators. And then for research question 3, Again, we were looking for that in-depth understanding of the barriers and facilitators, but specifically in the sectors of interest and in SMEs. So there were fewer studies in those settings. So we included all studies that were set in those settings or in SMEs, and that were judged to be of moderately reporting moderately rich data. So we needed to be a little bit more lenient with the richness of data because there was just fewer studies in those settings. So once we had identified our studies for research question 3, we extracted any quotes from the studies that described barriers or facilitators to implementation and organised the quotes according to Nielsen and Randall's framework, which describes factors that influence the implementation of organisational interventions in the workplace. So the framework has 3 main domains, as you'll see on the slide here. There's context, intervention, design and implementation, and mental models. We found a lot of quotes under intervention, design and implementation, so we actually decided to split that into 2 separate domains, which were, you can see under that main title, intervention activities, as well as implementation strategies. So within this model, in context, context would include omnibus and discrete factors that may help or hinder the intervention. So this includes contextual factors associated with the specific organisation or department in which the intervention has been implemented, or within the wider contextual factors such as cultural factors. So maybe there tends to be a lot of mental health stigma in a specific sector, or maybe there's been a significant organisational change, for example. And it also includes global factors, for example, the impact of COVID-19. In intervention, design and implementation, we've got factors relating to who initiated the intervention. And then in intervention activities, this includes factors relating to the design of the intervention. So whether there was a risk assessment done, whether there was any action plans in place, for example. And then implementation strategy includes factors like who drove the change and what level of involvement did people in the organisation take on, what communication channels were in place and what was communicated to who. And then we've got mental models. So this domain is more about whether employees were ready for change and what the participants' perception of the intervention was. Was there any change in people's mental models? And as you can see from the arrows on this slide, each of these domains interacts with the other. They're not distinctly different. There's a lot of overlap and a lot of interaction between these different factors. And you'll also see that mental models there sits within the context of the intervention design and the implementation strategy, which then sits in the context of the wider context of the organisation or the country or globally. So after extracting hundreds of quotes, we thematically synthesised all the information under the 4 domains to reach 13 main findings. And I'll pass you over to Caleb, who is going to talk you through those findings now.
That's perfect. Thank you, Charlotte. Yeah, so as Charlotte summarized in a short sentence at the end there, so emerging from the 19 studies were, as she mentioned, hundreds of quotes or excerpts from each of those articles that provided evidence for something that was either a barrier or a facilitator to implementing a mental health intervention in the workplace. And as you mentioned, that we mapped them on the 4 different domains that we had identified. And so it's my privilege to get to walk you through the 13 findings that we have consolidated through our synthesis process. And so I'm going to start in the center, if I can, and describe those findings that relate to the intervention activities and implementation strategy. I'm going to start here because it's here where we think there's the maximum level of intervention exposure that takes place and where impact can be achieved. So we'll begin here and work our way out to the broader context, and then finally go back into the mental models domain to look at those outcomes. So the first category where we had the first two findings were related to intervention activities. And again, those factors relating to all aspects of the intervention activities. So the first finding is what we've called clarity matters. So a definition of this finding here is that clear and simple intervention components and designs were seen as a facilitator to implementing interventions. So further here, underneath the heading of clarity matters, you see that we found specific evidence in the construction, ICT, and healthcare settings for interventions being delivered in those settings. We found evidence that both the format and the content of the intervention itself matters. So with regards to formatting, facilitating factors were whether the intervention activities were easy to navigate and access, activities that were shorter in length were facilitative, and then those that offered variety in terms of delivery mode. With regards to the content of the interventions, materials designed to address specific needs of the organizations and particular sectors were valued by the employees. And again, a variety of content and types of activities were facilitative. For each of these findings, then, what our team has attempted to put together is some recommendations for future interventions. And so under this finding of clarity matters, we sort of have three recommendations. The first of which is to emphasize efficiency and accessibility through the user experience. The second being design tailored intervention material to the needs of the organization or sector. And the third one is vary content modalities of the ways in which the intervention activities is played out within an organization. The second finding under intervention activities, we've labeled facilitate dialogue and reflection. So this reflects the facilitative influence of those intervention activities that create and reinforce opportunities in the workplace for reflective dialogue regarding mental health, and particularly as it relates to their day-to-day work activities. Here, the recommendation is that interventions look to intentionally create and reinforce opportunities in the workplace to reflect on and discuss mental health both within peers, but across peers and their leaders in the workplace. And that was seen to be particularly important in the construction and healthcare settings. Moving to the second domain, we have four factors that we found evidence for under implementation strategies. Again, this is speaking to aspects like who drove the activities of the intervention, who drove the change, what level of involvement did different people in an organization take on, what channels were used to communicate activities about the activities of the intervention. So the first finding that we have, we've labeled leadership buy-in matters. Okay, so leadership buy-in is particularly important from top and local management, and is seen as important to engaging employees and creating opportunities for systematic change. For example, here, management sharing resources and communicating information about the intervention, actually actively attending intervention sessions or being a part of the intervention rolling out with their employees was important, and designating time for employees to complete the intervention is very important or facilitative. As a result here, we feel it's vitally important for interventions to secure leadership commitment to supporting the intervention activities actively and continuously. So it's not just a matter of signing off or giving approval for an intervention to take place. It's a matter of committing to being a part of the rollout and have continuous involvement in the activities of the intervention. The second finding with regards to implementation strategy is promoting engagement. So prompts and feedback can serve as important reminders to use the intervention or to engage, for employees to engage with the intervention, but it's important to note that the evidence suggests that they're not effective on their own. So additional strategies to consider may be personal communication from different change agents or champions within an organization, be it a local champion, a HR manager, etc., to support the activities. So the recommendation here is that the intervention strategy should be cognizant of balancing promotion efforts from both within the intervention itself, so embedded within the intervention are prompts or nudges to engage with the material, whatever the format, but also that come from outside of the intervention, as I mentioned, through local champions or different safety officers, even from within an organization. The third finding is we've called local visibility. And so really, there's clear evidence that suggests that the intervention being visible, either again via that local champion or by regular promotion of the intervention by management, is seen as key to intervention awareness and then motivation for individuals within an organization to participate and engage with the material. So as a result, it's important to ensure that the intervention is visible within the workplace. And so really that involves a lot of creative thinking that needs to happen of how you can get the intervention or your initiative in front of the employees in meaningful ways and at meaningful times when they can actually enact on or respond to that, in that pull to participating in an intervention program. The last finding under implementation strategy was called role clarity. So here the finding is that agreement and clarity of role in relation to implementation, i.e. who is responsible for monitoring and promoting intervention engagement and to what extent the leaders are involved in the intervention or supporting the implementation activities, is crucially important. And so it's very important then to establish clear roles and responsibilities during the implementation process of who is going to be responsible for what activities. If I pull out then, so that was a quick tour through the first 6 of the 13 findings. If I pull out from and away from the actual intervention activities, we did find we had 3 main findings that relate to the context that the intervention activities are delivered within. And you can remember, as Charlotte had mentioned earlier, it can include broader, more omnibus factors, or the contextual factors can be more discrete or relative to the intervention organization that it's being implemented in. So the 3 findings here I'll walk through. The first is healthy communication in the workplace. So good relationships between all stakeholders in an organization with existing communication channels is facilitated for intervention implementation. So within an organization, if there are existing productive and healthy communication channels, that is a contextual factor that is facilitative to implementing an intervention within. On the flip side, if the communication channels are broken or fractured or not productive or healthy within an organization, that's seen as a significant barrier for, again, you trying to, as a researcher or as an HR lead person looking to have an initiative within your organization, having that go well. So the result is, insofar as it is possible, efforts should be made to foster or establish effective and active communication channels between all stakeholders within an organization. The second one relates to, again, specifically more aspects of discrete context, is that do your intervention activities align and integrate with existing work routines? Scheduling and aligning intervention activities with those already occurring in the organization's routine were seen to facilitate intervention implementation, while workplace contextual factors, as was often seen within the ICT and construction sectors, contextual factors such as frequent interruptions or noise levels or shared workspaces. If you think of in the tech sector, sort of the open office plan, and resulting in frequent interruptions and noise levels were seen as significant barriers to participant engagement in intervention materials. In particular, several intervention activities that had guided audio components where they're trying to be engaged with in shared or loud settings in the case of healthcare or busy hospital settings. So with regard to this, the recommendation would be to look for opportunities to integrate and reinforce your intervention materials alongside local work processes, so allow it to adapt to that as the context of the organization dictates. Third finding we've labeled reputation, or establish a positive reputation. So here, building a positive reputation for the intervention before implementation is facilitative. This is especially true in the construction sector, where there may be skepticism towards such initiatives, or in the healthcare setting also, where there may be a plethora of other initiatives or activities that take place in those settings, where there are continually many sort of well-being or wellness initiatives or employee well-being initiatives that are taking place within the organization. Insofar as is possible, should seek to build a positive reputation before implementation by communicating the intervention in a very positive light. So if I move more to the level of the personnel now, or the specific individuals within the organization, we had 4 main findings that loaded under the mental models domain, and I'll walk you through these 4 now, and these are the final 4 of the 13. So the first is prior personal experience. So here, this finding was fairly universal across all of the sectors, but especially we found this with SMEs, is that recent experiences of stressful life events or stressful work experiences were considered to be a very motivating factor for top management, senior management, or owners to engaging with the mental health activities, both for themselves, but then to take a more proactive management strategy for promoting mental health in their workplace. So the recommendation here is that particularly at the recruitment or more introductory stages, when liaising about the potential to implement a mental health intervention, the activity should highlight to managers or owners that they may find the intervention beneficial if they themselves have experienced any stressful life events as it relates to your content. The second finding here, we've labeled sector-specific learning. So for employees in particular, learning about sector-specific information, i.e. the incidence rates of various mental health challenges, or learning about the prevalence or extent of the problems that may be faced within the organization is beneficial. However, it was noted in a few of the studies, in particular in the construction sector, that some personal characteristics may still act as a barrier here. So a more stoic attitude or more personality related factors that may be more prohibitive here in that regard. But whereas is possible, the intervention materials should provide relevant sector-specific information about mental health, which really helps to cultivate a fertile soil within the employees for engaging with the material. The third finding we've called personal relatability, and so this sort of is very closely tied to the previous finding in sector-specific learning, but a key motivator for engagement is that participants' beliefs that the intervention is relatable, i.e. it fits with their day-to-day work environment, their experiences, their lives, their abilities, and is of benefit to them. So sector-relevant examples or case scenarios are seen as a really good way to ensure relatability and reduce stigma-related barriers to engaging in mental health interventions. Though this may be challenging, the interventions, again, should seek to ensure congruence or alignment with their materials and the user's experience and ability levels within the organization. And the final finding that we had, we've labeled credibility. So this really has an impact of whether or not an individual within an organization is receptive to the intervention materials. So participant beliefs about the credibility increased support for the intervention and motivation for engagement. While this is similar to the reputation finding within context or at a more broader level, here the finding is more personal to an individual's perceptions. And so it's important to demonstrate intervention credibility before going for implementation, before getting them to try to use it. So that is a very quick whirlwind tour through the 13 factors and 13 findings, and we realized that there's a lot of information there. So as a team, what we had tried to produce was a 2-page resource wherein each of the findings are defined, basically a summary of what I've just tried to communicate with you now. And then on the flip side, an audit style question tool to support intervention development. And this resource will be made available on the MENTUPP website shortly. And so you can access this here again and continue to reference this as you might go through your work.
And Professor Arensman will give a further overview now about the MENTUPP project and how we will progress from here.
Thank you very much, Birgit. And just while you were talking there about the magic moments, I think MENTUPP arrives at a certain magic moment, but also just based on our experience throughout the pilot study and currently in the recruitment of SMEs for our large-scale implementation study, we also see the concern of managers, particularly in the health sector, that they think you can almost see them thinking, what if there would be another pandemic, or what if there would be another public health emergency? So when I just mentioned that point of preparedness, I think this is something where we can tap into that magic moment again in trying to work with the work sector in mental health promotion, in trying to be better prepared for the future as well. So yeah, I would like to summarize a few key points in terms of the next steps for MENTUPP. And I'm very pleased to say that we're obviously over 2 years en route with the whole very big MENTUPP consortium, which is a very interdisciplinary consortium. And we have finalized what I would refer to as an overall successful pilot study. And we're now at the threshold of starting the large-scale implementation and evaluation study. So we refer to that as the cluster randomized controlled trial. And I would like to mention already, even in the subgroup I was in, there are people from SMEs, so certainly for SMEs in ICT and construction, the door is still open for you to express an interest to participate. So in the middle of June, we will start with the trial in all the 9 intervention countries, whereby following a randomization procedure, certain SMEs will be randomized to the intervention condition, and some SMEs, half of them, will be randomized to the waitlist condition, which means that after 13 months of the implementation and evaluation, the waitlist SMEs will also get sustainable access to the MENTUPP Hub. And this, following the pilot study, this is the main route for evaluation to determine the overall effectiveness of the MENTUPP Hub on many primary and secondary outcomes. Next slide, please. Yeah, so we are just finalizing outcomes of the MENTUPP pilot study, which will be shared via various dissemination channels over the coming months. When we start with the trial in the middle of June, it will be over the course of 13 months with 2 follow-up assessments where we will be assessing the main primary and also secondary outcomes, with the main focus on verifying the impact on depressive symptoms, anxiety symptoms, but also the potential protective factors such as resilience and help-seeking behavior. Next slide, please. Yeah, so we are still in the process of recruitment. So as you could see from the previous slide, overall, we're aiming to randomize 54 SMEs across the construction sector, health and ICT. And at the moment, we have achieved a level of saturation in health, but we still have all doors open to welcome expressions of interest in the construction, but also the ICT sector. So people on the call could contact us even as quickly as after the webinar to see if there's still scope to participate. And it's across our 9 intervention countries, 8 countries in Europe, and also the centre in Queensland, Australian Institute for Suicide Research and Prevention, Griffith University in Australia. I also would like to highlight that obviously the MENTUPP hub and the resources are translated in all the languages of the respective countries, but we are also in the process of very quickly completing a specific Ukrainian version of all the MENTUPP hub resources, a Romanian version, a Polish version, and also a Turkish version. This is just for information that in terms of languages, we want to eliminate all barriers and open up all opportunities for people to participate. So what does it mean to be involved in the MENTUPP project, in the MENTUPP trial as an organization? So the main aspects that we ask is to start the communication about improving mental health in the workplace, facilitating access to the MENTUPP hub, and this is in very close cooperation with the research teams in all the intervention countries. And then step by step, from buy-in and engagement from management to spread the news across the SME, and there are no specific inclusion or exclusion criteria within the SME, so the MENTUPP hub can be accessed by everybody in the work setting. One of the aspects, and it came back briefly in our subgroup, is then how will the implementation work? And an important recommendation from the pilot study is in order to achieve long-term adherence, sustainability, we would recommend providing or allowing weekly access to the MENTUPP hub for approximately 15 or 20 minutes, as opposed to once-off huge blocks of time allocated. No, this sustainable approach over at least 6 months, weekly access, and if at all possible within the work hours, the work setting. All employees participating and having access to the MENTUPP hub would have access to the hub on an ongoing basis. Next slide, please. Yeah, so there are obviously multiple advantages in terms of availing of the MENTUPP hub resources and being involved. And whilst this is a fully EU-funded project, there are no costs attached to this evidence-based resource. And we already learned via the pilot that this was a very important benefit and advantage for people to participate. There are clear indications of being able to reduce absenteeism and also costs associated with that, and then subsequently also enhancement of productivity. There's a huge opportunity to work with us in building a best practice model, not only for the duration of the MENTUPP trial, but within the future, to have an integrative approach towards mental health promotion in the workplace in the long term. Because even after the trial at the end of next year, there are plans to build a sustainable business model around MENTUPP in order to sustain and expand MENTUPP for implementation in the wider workplace settings. And then I think some of the points that Caleb mentioned, that kind of the positive connotation and the reputation. So SMEs involved with MENTUPP also will be able to demonstrate that endorsement of mental health promotion with the many materials and resources that we will provide. So next slide, please. Yeah, so here's your opportunity, and as I say, there's still a huge opportunity for SMEs in construction and ICT to participate at this stage in MENTUPP and to be part of the large-scale trial, which is starting in June. So on this note, I would like to thank you also all for being here, everybody involved in this webinar, and hopefully some of you will be able to contact us to also engage with MENTUPP for the trial and hopefully in the longer term. So thank you very much.
Thank you very much. I think if we can generate some interest in it, that will be all the better as well from this morning's webinar. Just closing remarks from myself, we hope that you've found today informative, both regarding the MENTUPP study itself, but also the findings of our systematic review and the evidence for implementation of mental health interventions, particularly in small to medium enterprises and the sectors that we've focused in on. Now, at the very start of the early days of MENTUPP, we had conducted quite a rapid review of some of the key papers and existing systematic reviews looking at implementation. And we produced a guidance report that was informative for the MENTUPP team going into the pilot study to try and build in and counteract some of those implementation barriers that we had identified and to mitigate for those. Part of what we've been doing today, apart from disseminating the findings of the review that's now much further advanced and completed, and particularly answering question 3, is that we want to then use the evidence base from the systematic review and the discussions that we've had today from, we consider you experts having attended this webinar, to revise that guidance report. So the discussions that we've had today have been really important to us. Discussions have been recorded, and we will use anonymised knowledge, just the key points that people have been made. We'll go back and look at our guidance report to see if there's any way that we need to revise or update that guidance report. So your input today is actually valuable to us and worth something. So the guidance report will be updated, and that's, as I say, it consists of the evidence from the review, but also expert feedback and consideration of that evidence as well, and input from actual sectors themselves of useful and helpful ways that we can encourage better implementation in the long run. So thank you very much for that. A copy of the presentation will be made available following the webinar today, and then further down the line, other outputs from the project, such as the guidance report and the systematic review itself, will be made available, particularly post-publication. So there will be lots of knowledge and information available on the MENTUPP website. So again, we would encourage you to go and have a look at that and keep up to date with outputs as we load them up onto the website. So I think really the final remark is just to say thank you very much for your time today. I'm going to pass over to Birgit Greiner, who just wants to inform people about an associated course that's ongoing at UCC, and I'll let Birgit say the final farewell to everyone as well. Thank you.
Thank you, Margaret. Just a piece of information: if somebody of you, or if you know of somebody who wants to study mental health promotion more in detail at master's level, there is a course offered at UCC, an MSc in Occupational Health. There is an online version of the course. You can do it from anywhere in the world, as well as a campus-based course. And we integrated into a health and safety approach, also training and development approach. So there are different topics that come into how to create healthy workplaces. So for instance, psychosocial risk assessment and management will be integrated as well, work stress factors, and so on. So if you know of anybody, please Google MSc Occupational Health at UCC, and you may enjoy these part-time courses over 2 years. Thank you very much for your attendance altogether. I think it was a very enjoyable morning. And you please stay in touch. You will also hear from us in terms of the set of the slide and the presentations. And I hope that some of you will maybe decide to join MENTUPP and get their organization signed up for our very exciting and unique trial. Thank you. That concludes the session. Thank you for your attendance.